Welcome, welcome. I am like stuttering because it's been so long. I'm so excited. I feel like Ashley, I don't know, how much you know, but our guests know, but I've been on maternity leave and I've also been kind of stepping back from doing live streams as frequently as I used to just because of time and life. And so it's so exciting to be back. And today we're here with a topic that is obviously both timely for me, but also one I'm really, really excited about. So we'll do introductions and hop in just a little bit. But for now, welcome you guys. So excited to be back on an IOCDF live stream and to join you all today for our incredible both content and then of course live discussion, which is my favorite part. So please make sure you guys tell us hi and put comments in the right hand pane in the comment section. Let us know where you're calling from. Let us know questions or content you want us to cover today. We are both excited and happy to cover anything related to anxiety, OCD, and all the stuff. So as always, and you guys know, our live streams are intended to be educational. They should not replace therapy, individual therapy of any kind. Instead, they're meant to help support, promote, encourage you to ask questions, but really promote the work that you do in individual sessions. In addition, IOCDF is not a crisis line. If you're feeling unsafe or suicidal, please call 911, 988, or follow your local emergency services. Today, our goal of all the live streams is that we can provide great education, great support, and of course, lots of feedback and thoughts about questions that you have or therapy that you're currently doing. As always, you guys can visit iocdf.org/peace of mind to learn more about upcoming programming, upcoming live streams. And this is also where you should go to submit content that you want from us. That's really important. So, when we first developed these live streams years ago, our goal was that we could bring education and content from leading experts across the country straight to you guys for free. And so we want to keep promoting that. But of course, we want to make sure we're doing what y'all want. So, put the content you want to hear. We always love to guess and we feel pretty good about the content we bring, but we want to hear from you. Make sure we're doing what you want. And that if there's anything we're missing, please make sure you tell us. Of course, additional resources and support can always be found at iocdf.org. So today we are going to talk all about women in mental health. We're really trying to use this live stream to highlight women in mental health, but of course we'll talk all things mental health. And so we are joined by an incredible expert and advocate, Ashley Ordway, who is going to share a lot about both perinatal, postnatal, so kind of that postpartum and peripartum, so pregnancy periods for individuals with OCD, anxiety, and related disorders. And then also we'll talk all things in general. So Ashley, please take a second to introduce yourself, tell us where you're from and how you got interested in this niche area of OCD and mental health treatment.
Yeah, of course. Hi, everyone. My name is Ashley Liz. I'm so excited to get to be the person to be back with you on your first time back. It's so exciting. I'm a licensed mental health counselor. I'm based in Gainesville, Florida, so Central Florida, right next to the University of Florida. And that is where I did all of my training. So undergrad, graduate school, registered internship was all at UF. And that is where I fell in love with OCD and anxiety-related disorders. At the University of Florida, we have an intensive outpatient program and multiple research labs that focus on OCD and anxiety-related disorders. And when I was in grad school, I got the opportunity to have Dr. McNamara be my mentor. And I joined on some cases with him and just was really drawn to the ability to get in the trenches with your patient, whether it be an adult or children, and we'll kind of walk alongside them in their mental health journey.
So excited. Well, that's awesome. And we love the work. And, I think let's kind of start there of just how much does mental health or OCD treatment, both assessment, diagnosis, and treatment change when we're talking about it being for women in the perinatal and postnatal period, postpartum period versus in general?
Yeah. So we know that oftentimes women who are either perinatal or postpartum can often experience, a lot of different emotions or thoughts they're not used to feeling, specifically around their children. And they can be really scary, similar to any intrusive thought. But oftentimes because they're surrounded or related to their children, they have a really hard time reaching out to professionals, whether it be their child's pediatrician or their OBGYN or their psychiatrist, really relate to the fear of what if I say something and someone takes my baby away, right? Or thinks that I'm a danger to my child and they don't understand the nature of my thoughts. So I'm just not going to say anything to anyone and kind of hope that these thoughts or the way I'm feeling will just go away. right? And so we will often see, especially in my experience, that we won't see women in our clinic until they're on their second or third child, and these symptoms have never gone away. They've just increased, and they're kind of at this place they can't move on or live life without additional help. And so a lot of what my work has been focused on has been increasing psychoeducation to psychiatrists, to psychiatry residents, to pediatricians, to OB/GYNs on kind of what to look for and what to ask and how to ask it, because that can really impact on what a mom is willing to say, right? I often use my own experience as an example, because whenever I had my babies, I remember being in the hospital and the nurse saying, "Hey, Ashley, you're not having any thoughts of like wanting to harm yourself or your baby, right?" And I knew in that moment, like, well, I wasn't, but if I was, that nurse was not going to be the person that I wanted to tell because of the way that they phrased that question, right? Of almost guiding me to say, well, no, of course not, right? And so I'm really trying to teach clinicians to not be afraid to ask those tough questions, and to ask them in a way that allows the patient to be honest with what they're saying. And a big way to do that is to provide normalcy to what some of those thoughts might be. So even phrasing it like, lots of women, lots of mothers have really scary, intrusive thoughts about themselves, about their babies, about harming their babies. It's a pretty normative thing after birth. Have you ever experienced that? Versus like, you're not experiencing this, right?
And I guess a question I have is, because I get this all the time is, in general, we get this without mothers. People will say things like, well, how do I know if I need to seek treatment? Like, how do I know if it's just kind of normal, right? All moms are going to have new intrusive thoughts. They're going to have random things. I remember, as somebody who's lived with OCD for a long time, obviously I can recognize when it's an OCD thought, if I have a sexual intrusive thought or harm intrusive thought or whatever it is. And I remember saying to my husband, do you ever have like weird thoughts about our kids? And he's like, yeah, all the time. But it was interesting because I was like, oh, I didn't even know that he had recognition that he's having those and that happens. But I thought it was interesting that he's never talked to me about it, because it also made me realize, they don't bother him, right? He recognizes he has the thoughts, but they don't bother him. He doesn't do anything about them, where I obviously have a lot of insight into knowing, so I'm in a different place. But if 5 or 10 years ago, those were some of my first thoughts, they would have terrified me, right? As someone with anxiety disorder and with OCD, and I would have started to dread or be terrified of being alone with my kids and all the things, all the safety behaviors that might have followed. And so my question is, how and what would you say to a new mom of like, how do they differentiate just kind of, here's some normal things to expect during these periods, both perinatal and postpartum, versus here's when you might want to seek treatment?
Yeah, that's a great question. So really similar to when we think about how we treat OCD in general, right? That like everyone gets intrusive thoughts, but when they start becoming really sticky and distressing, and we start noticing that our behavior is changing drastically because of those thoughts, and we're no longer doing things that we would typically be doing. And so I'd really encourage moms to reach out for help if they're noticing like, I'm really unable to let anyone else help me, right? Like, I know that I need help, but I want help with simple things like washing bottles or helping put baby to bed or changing diapers, but my brain is not allowing anyone else to help me, and almost to my detriment, right? So since I'm not having any help, I'm not getting good sleep, I'm not taking good care of myself. That's like a great sign that like we need some additional help and we need to seek assistance.
So one thing that I found is that before my first baby, I feel like people did not warn me for what this period could feel like. And as somebody who's lived with mental health disorders for a long time, I do feel like I was decently prepared, so some examples are that I had like a whole team set up, like my treatment team. I felt really prepared for intrusive thoughts and what might happen. I've talked about this on a live stream before. However, I wasn't prepared for these like hormonal feelings and just general feelings of like depression and anxiety. I feel like I was really equipped for OCD. So I was kind of like prepared that, oh, I'm probably going to have all these intrusive thoughts and my OCD is going to really ramp up and here's what to expect. And so when those came up, I knew what to do. Like I very much was working with my clinician and figuring it out and talking with my spouse and kind of getting myself set up to address those. But what I wasn't prepared for is the depression that showed up, the guilt, the shame, like a lot of these feelings that I had never really experienced in that magnitude, right? That just like increases during motherhood or during, when you become a parent. And I'm just really curious of how we can help individuals prepare for that, or like, is that just normal? Should they expect that? Like, what do they do with those? Because even now, like being postpartum 6 weeks with twins, I feel it a lot, and I feel it more at certain times. Like, I'll be honest, like when I'm pumping or provide, right? Like certain things that I can feel when the hormonal shift happens, I literally feel this sense of dread, like this like wave of depression.
And a lot of women feel that when they're like pumping or getting ready to breastfeed, right? That letdown feeling often leads to, you're saying, like that big feeling of like doom and dread.
Yes. Right? And I felt it with my first two. So with these babies, I was ready for it. I still don't like it. But at least I can label it. I know what it is. I know it'll pass. Like I have the appropriate awareness of it for it to be something that can come and go. But how do we help educate people more on just kind of like, this is what might happen, and here's what to do, and here's how to treat it?
Yeah. So in a perfect world, right, we know that psychoeducation actually has a huge impact on women's symptoms. It's why I'm a huge advocate for psychoeducation during pregnancy and before pregnancy, right? Even just being aware, like you're saying, like I knew what to look for. I knew it was going to happen. I was like on, right, like the kind of the lookout for these OCD symptoms, for these things, because I knew what to expect, even if I wasn't expecting it yet. That is what's going to be really helpful to a lot of women if we do have providers that are willing to share, like, hey, not just OCD, not just anxiety, but depression or even psychosis. Like these are the things to look out for. This is what those symptoms are. And this is what you can do when you're experiencing these symptoms is going to be the most helpful for everyone. And so if you don't have a provider that is willing to talk about those things, or you don't know how to ask your provider about those things, IFCDF, right, their website is a great resource for that. And even reading on the perinatal postpartum page. But being prepared of knowing what to look for, and even having like your partner or spouse or friends knowing what to look for as well. So that if you're experiencing it, but you are able to recognize it for yourself, that someone else is there to support you and be like, hey, I think that you might be experiencing some depression more than just baby blues. Let me help support you and find someone for you to talk to.
100%. And so what I want people to take away is that, we do know that these periods, so, pre-pregnant, pre-baby and post-baby periods, you are at an increased risk of mental health, right? Of both OCD increases, anxiety increases, depression, kind of name it. And so the more we're aware of our vulnerabilities, the more we can be equipped to how to handle them. But also many people may say, well, I already went through those periods and struggled with this, but we want to really be able to help normalize that this is very common, that individuals do have the onset of symptoms during these periods, or they see a big increase in symptoms during these periods. My question to you, Ashley, is how often do you see people receive a first diagnosis of anxiety, mental health disorders, depression, or OCD during these periods?
Yeah. So in my personal clinical experience, either most mothers already knew ahead of time of like, hey, I've had depression or anxiety or OCD throughout my life and I've gotten help or treatment for it, or that they've been like, yes, I know I maybe struggle with anxiety, but it wasn't that impactful in my life, or I kind of recognized it, but I was kind of able to manage it on my own until I got pregnant or until I had children. And then I realized like, oh, now my anxiety is at a place that I can't just self-manage and that I need additional help. I have had a handful of people who have come in who have been like, I've never experienced any OCD symptoms or any anxiety symptoms ever in my life that I can remember. And now I am in the perinatal stage. That's far less common than the other two.
Yeah. Yeah. And yeah, so same. So I've seen a lot of cases of postpartum OCD where most of those folks did have OCD symptoms throughout their life, but yeah, they weren't seeking treatment for them because they were able to manage it. But in the postpartum period, right, it became more unmanageable or more disruptive. And that is when they did seek treatment. Yeah. So let's hop into questions. You guys are starting to post them. So let's start there. And then of course, we'll go through some pre-submitted ones as well. So somebody talked about Arthur at 1102 said they're from Massachusetts and their son is dealing with contamination OCD. So Ashley, do you want to just share some thoughts about how individuals can understand contamination OCD, both family members understanding what that looks like and feels like for the patient living with it, and then also, of course, what treatment might look like?
Yeah. Hi, Arthur. Thanks for reaching out. So contamination OCD is definitely a tricky one to work with. And I think what's most helpful for parents and families to understand is that the core OCD is not rational and doesn't make sense, right? So oftentimes when I see parents with kids with contamination OCD, they'll say things like, they take 3-hour showers every day, but their room is a mess. And I don't understand, like, how could they be doing X, but not Y? And I really just want them to clean their room. And if they really had OCD, wouldn't they want the room to be clean and be doing all these other things? And so I think reminding ourselves that, like, at its core, OCD is never going to make sense. It's not rational. Trying to rationalize it is just going to make ourselves go wild, right? We're never going to get that core answer we're looking for. And then really recognizing how much like family accommodation and reassurance play a part in OCD, and working with a provider that can help you be able to put those boundaries in, be able to decrease accommodation and decrease reassurance in a really systematic and helpful way.
100%. And so let's talk a little bit about just what it might look like in general, right? So yes, I think in general, most people, when they think of contamination, they think of kind of that traditional fear of germs, fear of illness, which it definitely can be. We also can see fear of chemicals. We can see fear of illnesses like COVID, diseases, that sort of thing. But also very common with OCD can be this fear of bloodborne illnesses, fear of a particular like pollutant, right? All sorts of ways it can look. And so I just want to be candid about that, because I think a great point you brought up, Ashley, is that a lot of people will tend to think things like, oh, well, that like they're not clean, there's no way they have contamination OCD, where really like maybe cleanliness is actually like not even a part of their compulsions because they have this other fear. Or maybe they're so triggered and struggling so much that instead they avoid. So that's really important to note too, is that avoidance plays just as big of a role in the cycle as rituals do. And many times, like a lot of patients that I know who struggle with fear of germs, fear of illness, you will see them go like weeks without showering or
brushing our teeth or things like that.
Yeah, normal hygiene practices. And people will say things like, well, how does that make sense? Like they're afraid of germs, they're afraid of contamination. Well, because if the rituals around this have become so intense and so debilitating that they will start to avoid doing the behaviors altogether because it's so triggering for them, that is very, very common for us.
Yeah.
Awesome. So love to see all, you guys are so sweet. Everybody's asking lots of questions and having so many great comments. So we appreciate you. At 11:11, Amy said, if someone had postpartum depression, are they at higher risk of having postpartum OCD the next time?
Yeah. So we definitely know there's like a comorbidity between depression and anxiety. And research shows that about 14% to 15% of women with postpartum depression experience, we call it obsessive compulsive symptoms. And that in general, up to 63% of people with perinatal OCD will have comorbid depression. And so we know that they often can be linked together. And if your family member is experiencing OCD symptoms for the first time, their depression might be higher because of the OCD that they're experiencing as well.
Yes, 100%. Sorry, guys, I'm filtering through the questions live and pre-submitted. So let's hop to pre-submitted questions. One of the next ones we will ask is, when a terrible intrusive thought comes up, is it better to talk about the thought and discuss it with others, or is it better to not worry about them and let them flow through my brain?
That's a great question. Yeah. So it really depends on what you're looking for when you're talking with other people about them, right? If we're talking with other people about them as a way to like seek reassurance, right, or to ask questions about them, then we know that ultimately ends up making OCD worse long-term, even though we might feel better in the moment. But if you're talking with them with people as a way to challenge your thoughts, as a way to repeat them, as a way to lean into them, having those people to be there to support you can be really helpful to do that.
100%. I also think that it's, the thing I always talk a lot about, and you guys hear me on this horse, so to say, is function, right? What is the function of talking to someone about it? What is the function of not talking about it? If the function of not talking about it is, hey, this would be a ritual, I'm going to let that thought be there and move on, that's great. If the function of not talking about it is, I want to suppress this thought, I don't want to think about it, I'm scared of it, that actually is avoidance, it'll make it bigger. If the function of talking about it is, I want to talk about this so that I can get reassurance and feel better, it's going to actually enable your OCD. If the function of talking about it is, hey, I'm going to say this out loud, not expect any response, and it's going to be an exposure, that can be great. So again, I think it's really important to note that so many times I'll get asked questions, and we all will, about should I do this or that? And my answer is like, well, actually both could be an exposure or both could be a ritual. And so I want us to really be thinking about when we engage in a behavior, what is the function? If the function of it, no matter what it is to try to make ourselves feel better, to try to get rid of the anxiety or the thought, it's actually going to increase our anxiety or OCD, right? It's going to promote that circle, and we're going to get continuously stuck in that trap or in that loop. If the function of it is to be able to move through it and is more of an exposure in the sense that it's like, oh, that actually would be harder for me to do that. That would be a little bit more challenging or more difficult. That is most likely the way to go. Next question. How common is relevant OCD, and is it a clinically regarded form of OCD?
It is a real form of OCD that's clinically regarded, for sure. I'm unsure on like the percentage of like what percent of people experience real life OCD, but we know that OCD attaches to two main things, right? Things that have truth to them, and then things that we really care about. And so we know that a lot of people's OCD attaches to things that could be true or have truth, and then kind of implodes, right, those ideas.
100%. Yeah. So what I would say is we know that it can be just as common as any other subtype, and it is regarded. I think it's a little bit confusing because people are like, where does it fall within like some of the subtypes? Relevant OCD can trigger scrupulosity thoughts for someone. Relevant OCD can trigger harm thoughts. It can trigger sexual intrusive thoughts, contamination, right? It can trigger so many different things. And so I think worry less about the subtype, but know that it's less about like, what is this type of OCD? Because that actually doesn't really matter. We're going to treat it the same, right? We're still going to use ERP, whether it's relevant, whether it's scrupulosity, whether it's harm OCD. It's really about, is there unwanted intrusive thoughts? And people often feel like with real event, well, it's different because something actually happened, right? Or it's different because there was actually an incident. And while that is true to a degree that there might have been an incident or right, all of those things, it is very similar, right? In the sense that it is still something that happened, sure, but now your OCD has attached to it. And when you actually think about other types of OCD, it's not any different. So when you have a trigger, oftentimes, even if it's just a contamination trigger or you touch a doorknob and you're afraid you got a disease, there was still a real event that happened. You still touched that doorknob, right? There was still some sort of real event or real situation that then triggered your OCD, triggered this response. And so I want us to be really thoughtful about that I just want to talk about that for a second, that I think so many times people feel like, well, if I have this subtype, it's different, right? If I have mental compulsions, the treatment is different. It's not going to work the same. If I have scrupulosity, it's going to be different. And the reality is that that's actually not the case, right? Treatment works for any subtype and type of OCD, and it's the same treatment. Yes, the way we might engage with it looks a little bit different, but the treatment is the same, and that's so important to be thoughtful of. I love Amy's comment. She said, I think sometimes people think that OCD subtypes are diagnostic criteria, but OCD is the diagnosis. Dr. Saxena always explains this really well, and I love that.
Yeah, that's great.
All right. Next question. What clinically is the most effective treatment for OCD from a purely cognitive perspective? So if you just want to share a little bit about CBT in general and how OCD treatment has kind of been derived.
Yeah. So cognitive behavioral therapy, or CBT, right? The way that I best describe it to my patients is that the thoughts we have, right, affect the way that we feel, which then affects future behavior. So the example that I give often is related to where we live, but where we live, there's a mall and it has a Chick-fil-A in it. That's a very frequented Chick-fil-A. And I'll say, you know, if you're in line at the Chick-fil-A and everyone works with a kid, or like if you're in line at Chick-fil-A and you see a kid from your class and you wave to them, and they don't wave back, right? And our first thought is, oh my goodness, that kid does not like me. They did not wave back to me when I saw them in the Chick-fil-A line. And so we feel really bad about ourselves because why doesn't this kid in our class like us? And so the next time we see them in school, way less likely to say hello to them because, well, they don't like us. And we felt really bad when we saw them in the line at Chick-fil-A when they didn't wave back. But if we wave to someone and they don't wave back to us, and our first thought is, well, they just didn't see me. Well, then we kind of feel neutral about it. We don't feel bad about ourselves. They just didn't see us. And we're much more likely to go say hello to them the next time that we see them in school because, well, they just didn't see us when we waved to them the first time. And both times it's the exact same event, but the way that we thought about it had a huge effect on how we felt and then also our behavior later.
Yeah.
And when it comes to the CBT part of CBT with ERP, so exposure response prevention, it's that cognitive piece that really targets our thoughts that are behind those compulsions that we're engaging in, that we're trying to neutralize those thoughts with.
100%. Yeah. Couldn't have said it better. Nothing to add there. Next question is, I really haven't struggled. Well, we'll skip that one for another live stream because it's eating disorder focused. What should I do when the thoughts just keep flooding in and I can't get relief? They feel so real and so important.
Yeah, that's a great question. So there are lots of things that you can do. So we know that saying our thoughts out loud, right, is one of the most helpful things that we can do because we can start separating ourselves from our thoughts. And when we say our thoughts out loud, trying hard to not reassure ourselves as we're saying them, but just leaning in and repeating what the intrusive thought is. If it feels too hard to do that, writing it down over and over can be helpful, or even writing it as you're saying it out loud, incorporating those thoughts into a story, or even if you're like, all of that sounds too hard, even just like writing the first letter of your thoughts, right? The first sentence, just words, anything to kind of get it out of your brain and onto paper or out loud. We know that when our thoughts are in our brain, they feel so scary and so much louder and bigger than when we start saying them out loud. And oftentimes OCD will say, hey, you should never say these things out loud or write them down because they're more likely to become true. And we know that OCD never tells the truth, right? And the main reason that OCD doesn't want us to say them out loud is OCD knows that it starts to lose its power as soon as we do that.
Yeah, we talk about this all the time at the clinic, that if this LaCroix was contaminated, and when I am doing an exposure around it, we can all agree I would probably need to touch it and not wash my hands or whatever my ritual is. But if when I'm doing the exposure, the way I approach it or touch it is this like, I'm terrified of you way, I'm actually reinforcing that message that this is dangerous, this is scary, this is anxiety provoking. And my response and my body's response, so my body's ability to see it as not being dangerous, to habituate, it's actually going to come much slower, right? Or it might not even really happen at all because I'm still treating it as if it's really scary. And so instead, if when I'm doing an exposure, I like touch it and even if I say to you, well, I feel really terrified, but right, I'm still touching it in this like neutral way and I'm fully cross-contaminating and I'm really embracing it and I'm letting myself feel the discomfort, the distress, all the things from this contaminated cup, I'm actually going to change my relationship with it. And so when we think about thoughts, they're really no different. If we're like afraid to say them and we're, afraid to think about them and we're trying to suppress them and push them away, we're sending the message they're really dangerous, right? We're sending the message that we shouldn't be having these thoughts. Versus if we're able to say them out loud, that's kind of the same as like fully touching this cup, right? You're like, yeah, like, okay, here's this thought. It scares me. And like, let's keep, and sometimes we're going to ask you, keep repeating it, keep saying it until we notice that you're not saying it in this like, shaky tone or rapid way. And instead you're saying it in this neutral, calm voice where you're letting it just be a thought, just a flow of conscious that's coming out of your mouth versus I'm treating it as if it's an intrusive thought.
Mm-hmm. Yeah, exactly. And even times with like my younger adults or kids, I can have them sing it, right, or say it in all different accents they can think of, right? Just trying to do it in a way that feels doable, right? Exposures are meant to be challenging but doable.
I love that. Yeah, I oftentimes will tell people too, like the more we can. So one of my favorite sayings is, imagine if you can get to a place where you can have thoughts, but they're not triggers.
Mm-hmm.
And the reality is that means we have to treat it as a thought, not a trigger, And so, yes, we need to start singing it and doing these things that it feels like, why would I do that? This isn't a fun thought. This isn't a thought I enjoy. It's like, well, yeah, but we just want to make it be a thought. And the only way we can do that is if we treat it as that. But if we keep treating it as a trigger, it's going to keep feeling triggering. So the next question that I'm going to answer was pre-submitted. They said, how can you work through intense anger after being treated badly at a job and having lost confidence in yourself, and now you're doing intensive therapy? How do we come out on the other end after a supervisor at a job discloses personal mental health information about you without your permission or knowledge to other staff members and then forces you to go on a leave of absence? This is a really tough question. Yeah, I don't know how to totally answer it, because there's certainly no right way to approach it or answer this. I think that first and foremost, you kind of have to decide what action or how you're going to respond if you would want to go back to that job, if you feel like you wouldn't be able to and that you need a fresh start and to start over. But what I would say is that across the board, I first of all, when people have really difficult mental health, like mental health stigma related experiences, I want to just validate how hard that must be. And you're already going through your own mental health struggles. You're already struggling with having to seek treatment, having to deal with this. And so to have somebody else not just not understand it, but be really ignorant and treat it in a absolutely inappropriate way is something that nobody should have to navigate. And you do in this case, right? And that's the reality, is that, like, yes, I wish I didn't have to do this or go through this, but I do, and I've already experienced this. And so we still want to use kind of a CBT approach, actually, of, okay, this is really hard. This is not okay. We don't want to sit there and say, oh, it's okay they did that. No, it's not okay they did that. We want to be able to recognize that and talk about it. And how can I move through it? Because I want you to be able to have a corrective experience at a new job. I also want you to be able to have a corrective experience in being able to disclose your OCD or mental health with someone else, right? We don't want you to think that now you can never talk to people about your mental health because you're always going to have this negative experience like you did in this case. And so we want to be able to really help you work through that and navigate that appropriately. And so what I would say is, what's the best way to deal with this? I think you have to decide if you want to talk to some of your other coworkers, what decisions you're going to make around that past job. If you're going to think about going back there, if you're going to go to a new job, if you're going to approach this with HR, if you're going to talk to your coworkers, like those are decisions you have to make. You want to make decisions on that. Once you make decisions, we want you to move forward. So we want you to be either applying to a new job, figuring out how you're going to return to that job, thinking about the ways that you might approach this past employee that did this. If in fact you're going to have to work with them again, maybe you choose not to go back there and you won't work with them again. But, it's one of those things that I think intense anger, guilt, shame, these feelings that we get that are not OCD, but maybe they're because of our OCD, it then elicited things that happened that caused this, response or situation. They're not fun and they're real. And when you think about how you work through OCD, you work through it by moving through these real feelings, right? We don't suppress feelings. We don't try to ignore feelings because that doesn't make it better, right? We need to work through them. So you need to be able to process the anger, process the situation, and then decide what are the decisions I'm going to make and how do I move forward and move through it. Because the more we try to suppress it or, just the more we feel it in the sense that I'm just going to keep being mad and I'm going to keep figuring that out, it actually keeps us stuck. We did an entire podcast episode on Anxiety Society podcast yesterday. So it'll be, launching in a few weeks to a month or so. But the whole episode was on how do we process productively? I think a lot of times for many of us, we think processing is continuing to talk about a certain situation and, seeking lots of advice and feedback, but that can actually keep us stuck, right? We're not actually processing. We're just stuck in the anger, right? Stuck in that one feeling. Processing is how can we actually move through it? How can we let go? How can we get to a different place, right? And so I think that's such an important tool to learn in life. And it also is applicable when you do OCD treatment. Ashley, anything you have to add?
No, you said that perfectly. That was great.
So next question is, I've developed something where I will do an action to make myself worry. Like if I slow down in front of a car, I feel like I'm being risky when the risk is minimal, even if it happens without me. So we see this sometimes with OCD or anxiety where individuals they do something and then they start to think, oh, I did that on purpose, or I wish I was being reckless, right? But it's OCD starts to target actions after they've been engaged in. How do you recommend somebody works through that?
Yeah, in the same way that we work through anything else, or leaning into that uncertainty, right? So trying to not reassure ourselves and being no, it was fine. It wasn't actually reckless, right? I did it on purpose. I was in control, but leaning into like the maybe not, right? And kind of like leaning in, especially since the action is already done, and leaning into that uncertainty part of like, we don't really know why we did that, or we're not really certain on if you're being reckless or not, right? And trying to lean into the uncertainty.
100%. Next question is, have you heard the saying, the only thing to fear is fear itself? For me, I fear like having severe OCD. For me, I fear having severe OCD symptoms again more than anything else. I just don't want to end up like Howard Hughes. So let's talk a little bit about that. But the fear of fear, tell us about it, Ashley.
Yeah, the fear of fear. The fear of fear, I think, can be some of the most like paralyzing type of fear, right? Because we're kind of always searching and looking out to see if we are afraid, right? And it kind of almost negatively impacts how great we're already feeling. Like, it sounds like this person has made so much progress in therapy and is past that stage, but now is kind of on the lookout. I'm kind of waiting for like the other shoe to drop of like, oh, now I'm afraid that this is going to happen again. And so oftentimes I think with OCD loves for us to be focused on things we have yet to accomplish, or things that could potentially happen, or OCD triggers that could come up again, and it kind of keeps us stuck. And so I think in this instance, really trying to focus on all the amazing things you've done and challenged and worked on to get to the place that you're at, where that now that you're fearing, right, these things could come back. That means that you've already surpassed them and have done them. And to trying each day to be your focus versus focusing on, what if this happens again? What if I do something or slip up or not so vigilant, right, that I allow these things to come back?
100%. And what I will say is that actually this is one of the biggest parts of OCD as well, right? When you think about most people's anxiety and OCD at the core, so when we really do that Socratic questioning, get to what are the core fears, a lot of people's core fears are the fear of being anxious, right? So it's that fear of, well, if I don't do this now, I'm going to think about this forever, or I'm going to experience guilt forever, or I am going to, never be able to experience something fun or a good time or a good situation because I'm going to be preoccupied or worried about it. And all of those really are, I'm afraid of fear, right? I have the fear of being fearful, the fear of being anxious, the fear of being uncomfortable, the fear of having discomfort. And so that in and of itself is a huge piece of OCD treatment, right? It's, can we lean into like, who knows what might happen in the future? And yeah, I'm scared that things might not be the way I want, or I might be triggered, or I might struggle. And that's actually okay. Next question is, my pure OCD compulsions was starting to think about a positive thought, and then I was able to function without worries. Since starting CBT and acceptance situation, it's much worse, and it's 2 years with no relief. I've never had such a long period of suffering. It was either 1 to 2 weeks max. Is CBT backfiring, and should I stop doing it?
Can you repeat like the first part of that question again?
Sure. Yeah, absolutely. So my pure OCD compulsions were starting to think about a positive thought, and then I would function. So basically when they had an intrusive thought, they would replace it with a positive thought. And they said that since starting CBT and acceptance, the situation is worse and they've had no relief.
I'm sorry to hear that you've had no relief and that things have gotten worse. Without really knowing like how long you've been doing therapy and things like that, right? We often know that OCD can get worse before it gets better when we start working on it and targeting it. OCD, more than anything, wants to be in charge, and when we start doing the opposite of what OCD wants, if we even think about the habituation curve, right, that OCD often, our intrusive thoughts get worse, our anxiety gets worse before it gets better. And so I'm wondering if that's a little bit of what's happening. And so I'd encourage you to continue through. I know that it's hard. Exposure therapy and CBT are some of the hardest therapies to do because you're going against everything that your brain is screaming at you to do. But I would definitely also talk with your provider about what you're feeling and how you're feeling to make sure you guys are all on the same page.
100%. And so what I want to say too, to add to this, is that I want us to really break down, and this will be a great little experiment for us to do, Ashley, is what ERP would actually look like for on an intrusive thought. So I think a lot of times when we think about CBT and acceptance, because I'm not hearing a lot about ERP here in this question, we see people doing things like, I had an intrusive thought and I'm just trying to accept that it might be true. And that's actually not what ERP is. ERP is not about saying, okay, maybe I am this terrible person and I'm always going to struggle and I just need to be okay with it. Like, yeah, you would feel worse after 2 years.
Yes.
It sounds terrible. Like, I don't want to do that either if that's what we're talking about in this situation. And instead, ERP is about accepting the unknown, allowing the thoughts to be there and doing nothing about them. It's not about trying to confirm a thought. So we don't need to accept our worst case thoughts as truth. If in fact, that's what I was asking people to do for therapy, most people would not want to go to treatment, right? Like, I know for me with my sexual intrusive thoughts, if someone said, okay, part of therapy means you just need to be okay with those thoughts, my answer would be, well, then I'm not doing therapy because I'm never going to be okay with being this person I know I'm not, or that I don't want to be. Same with scrupulosity, right? Like if somebody said, okay, yeah, you need to just be okay with your blasphemous thoughts and not care if you have them, and I need you to get to that place where they don't matter. That's not possible for me, right? Because it's important to me and they go against my values. They go against who I am as a person. That is a big piece of what we know about OCD treatment. And so I say this all to say that I just want us to be really, really thoughtful about what are exposures, what is ERP looking like when we have these unwanted intrusive thoughts. So what it looks like is being able to say, like, for example, let's say I have this unwanted harm intrusive thought, right? ERP is in that moment being able to let the thought be there. So saying like, man, ugh, I hate that thought. And there it is. I'm having this thought about hurting my kid. And I'm going to choose to not figure it out. I'm going to choose to not solve it, to not understand it, and keep moving forward. And so it's about being able to engaging in response prevention. So I'm not going to ritualize. I'm not going to figure out what does it mean? Did I do something wrong? Is everything okay? Right. I'm not going to use OCD behaviors for this unwanted thought that I'm having. And I'm not going to try to suppress it. Oh, I don't want to have this thought. I don't want it to be there. But I'm not going to sit there and say, oh, yeah, maybe I am going to harm my kid. Maybe I am this terrible person. Oh, I need to accept that might happen. I might be this monster. I might harm my kid. No, I'm not going to do that either, because guess what? Like, that's actually not who I am. I don't need to do that to get better. And so instead, what it's about, acceptance is about accepting that the presence of the thought, not the content of the thought. So think about that. Like, can you accept that the thought is there? And that the thought even sucks. You don't like it. You don't want it, but you're going to choose to not do anything about it versus, oh, I need to accept that the content of the thought, like I need to accept that thought's okay and be okay with it. Those are two totally different things.
Yeah. And sounds like with what you're doing, you're living in a lot more alignment with what your values are, right? Versus what OCD's values are, right? And so being like, I'm going to try to figure out this thought and why I'm having it. Being like, no, I'm in the middle of making dinner for my kids. I'm going to keep doing that, right? Versus whatever else OCD wants you to be doing.
100%. Couldn't agree more. Next question is, does anyone experience while taking a shower that they start ruminating from everything in their past? Showering takes such a long time.
Yeah. I feel like a lot of people have that experience, right? Because we're in the shower, there's nothing really much to do or to think about other than sit with our thoughts. And so similar to like that time right before we fall asleep in bed, right? Where people will say like, I'm getting in bed and now the brain is going wild. And it's because our body is finally calm, right? We're not having to do all the things that life asks us to do each day. And so I think it's a very common experience to have.
100%. So yeah, I couldn't agree more. And I think that's just so critical to talk about, is that when things are slow, people often talk about this, and I talk about this, that when I was really struggling with OCD, I never would have wanted to like go on a beach vacation and sit at the beach or read a book or do things that when my mind was quiet, because I found my OCD was louder. However, what I want to tell you is that also is indicative, you guys, that you still have work to do. We should not have to go through life being afraid of our mind being quiet, because if we're quiet, then our OCD will show up. That is actually not helpful. So instead, what's more helpful is to say, why am I afraid of things being quiet? What intrusive thoughts show up that I'm still getting triggered by? And let's do the active ERP around that. Because I want you to be able to meditate, to go to a yoga class, to get a massage, to read a book, to be able to be in quiet spaces and enjoy it, versus being afraid of quiet times because you're afraid of what thoughts might show up. And so if you still have a fear of certain thoughts or certain content or certain triggers, that is a good thing for you to talk about with your clinician about, hey, I feel like I still have some ERP to do in these areas because I find that this area for me is something I'm still kind of afraid of or something that I still struggle with when it shows up. Okay, there were so many questions. Sorry, I was going to pre-submitted questions, you guys, so now I've missed a ton of other questions. I love so many people recommending getting a dog and how dogs can be such a wonderful like treatment tool, and they stop you from isolating, and you have to get up and be out and about and all the different things. All right, so first pre-submitted is I'm hyper aware of my swallowing when I try to sleep. It keeps me awake for 2 days. I physically can't switch it off. Mindfulness isn't working as expected. So actually what I would say to this is I wouldn't expect mindfulness to work, right? Mindfulness is going to get more stuck. This is where you got to work on it doing active ERP. So I want you to talk with your clinician about coming up with a plan around it. But this is where mindfulness is more of a distraction technique, right? You're trying to distract yourself from the thought. So it might work a little bit, but it is certainly not going to be treatment. That thought is still going to be there. And as you're experiencing, the thought is actually overpowering the mindfulness. So we want you doing active ERP so that you can really get some good relief that you deserve from these intrusive thoughts. Next comment at 11:30 is my harm themes around dogs led to overcompensation and compulsions. Except for keeping them on a healthy diet, my dogs are pretty spoiled. So yeah, we can definitely see OCD and anxiety impact dogs, but I hope that we can, that greater good, that bigger picture, that big values-based work is that you love having a dog, you want to take care of them and have fun, and we can treat OCD there. Okay, so a lot of folks are talking about not having specialists in their area, so please make sure you visit iocdf.org to learn more about providers and provider options for you that may have both sliding scales, accept insurance, all the different things that would allow you to be able to have access to appropriate treatment. Next question from Amit. I have compulsive staring OCD. Is staring is obsession or a compulsion? Because it's really confusing. Some suggest that staring at private parts intentionally, some focus on eye contact. What should you do? So we've actually done an entire webinar on staring OCD. So I would definitely recommend watching that and thinking and kind of seeing the feedback and thoughts around this. But it is a really good question. And I think people get really stuck on like, so what is the compulsion versus the exposure? The exposure is actually less about intentionally staring, although you may do that at times together in session. It's much, and it certainly would be, again, exposure should always be something I'm willing to do and that we're willing to do together, not something that is uncomfortable and that you wouldn't do or goes against your values. So we want to make sure it's values-based. However, oftentimes for this type of treatment, it is going to be just engaging in everyday activities. So not engaging, but instead truly actively engaging. And when triggers come up, being able to move through them. So not looking away, not avoiding, right? Things that you would people you would typically talk to or look at and engage with and make eye contact with. Next question. So someone talked about how one of their core fears is the fear of fear. So we definitely see that. Next question at 11:36. I have maladaptive daydreaming issues since birth, which started in PCD, which started at age 15. The former makes it extremely hard to avoid mental compulsions. How should I stay present in the moment and not be distracted by my thoughts? So let's just talk for a second, if you want to, Ashley, about how individuals can get to a place of being present when they have OCD versus being taken away from moments because of their intrusive thoughts.
Yeah. And I love that they brought maladaptive daydreaming, because I feel like that's a big issue that a lot of people with OCD struggle with that isn't talked about as much. And I kind of touched upon it earlier, right? But oftentimes we can get really stuck on when we have an intrusive thought or we know we need to do an exposure of being like, okay, I need to do it right now. I need to know what the perfect exposure is, how to challenge this intrusive thought. And oftentimes the exposure itself is actually like living life, right? Of like whatever you're already doing in that moment, whether it's walking to class or making dinner or folding clothes or having fun with your friends, that's much more important like in that moment to be focused on what you would rather be doing than what OCD is saying to do. So having to stay in the present moment, it's hard, right? But kind of constantly bringing yourself back to like, well, what am I doing right now that I want to be doing versus what OCD is demanding of my time or of my thoughts or of my space. And you might have to do that over and over and over again. It's like an active choice, right? That you have to keep making, but keep bringing yourself back to whatever it is that you want to be doing, that you're choosing to do, versus what OCD is saying.
Next question. A lot of y'all are talking about meds. I would just encourage you guys to be careful sharing medication and medication doses in the comment section, just because it really should be individualized. We want you seeing your own individual psychiatrist and not comparing and thinking about someone else does this is what would work for me, and that sort of thing. A lot of you are sharing so much of your treatment experience and ERP and how it can work. I love this. I love seeing this. One person asked, what is the most promising non-pharmacological intervention that has the most evidence-based support for it? For instance, how about inference-based or metacognitive? ERP. So ERP is the most effective evidence-based intervention for OCD. It is the gold standard of treatment, and it should be the first line of treatment. And what we would tell people is that if you don't have an ERP clinician in your area that is accessible to you, we'd want you to consider some of the self-help and other modalities that really can help you learn, but help teach you about ERP and the process and what it looks like, because it is the most effective intervention, without a doubt, without question, for OCD treatment.
And definitely, if you're in an area that there are no adequate providers or providers that specialize in OCD or use ERP, definitely trying to even utilize like PsyPact and those things, and seeing providers that are in other areas can be a great resource too.
Couldn't agree more. And last question so far is, what are your thoughts about referring to our pre-OCD and past self for recovery? Sometimes it's a motivator, but sometimes it's also depressing.
So I'm guessing of almost in a way of being like, oh, I can't wait to get back to who I was before, or kind of get back to my old self. Yeah, I think that sometimes, like you're saying, it can feel depressing, right? Like, oh, will I ever feel that way again? Or however, we're kind of like idealizing our pre-OCD person, but kind of also have to remind ourselves that post-OCD and post-OCD treatment could be so much better than even what we thought we had pre-OCD.
Couldn't agree more. You said it amazingly. But yes, this is what I would say.
Mm-hmm.
I think that for so many of us, we might compare our pre-self, but what I would say is I actually want you to be excited about your post-self, because that post-self, yes, you've gone through OCD, which of course you wish you wouldn't have had to. You wish you wouldn't have had to go through the treatment, the struggles, all the things. Yet think about the strength that you will have, the resilience you'll have, and a better understanding. John Grayson talks about this all the time, but one of his famous sayings is that people who've gone through OCD treatment are better than the norm. And that really is so true, because when you think about like COVID and all of these really triggering situations that many people have to experience in their life, or had to, no matter what, individuals who had done OCD treatment and had done it well and were in recovery actually managed that so much better and managed stressful times in their life so much better than people who haven't. And again, another thing we talk about a ton on the podcast is that when you think about anxiety as a whole, most individuals don't have a lot of tolerance for anxiety, right? No one likes feeling anxious. Nobody likes the feelings, the thoughts, all the things that come with it. But if you've done treatment, and if you've done OCD or anxiety treatment and you've done it well, so you're in a place of recovery, wow, you have tools that anybody could use and benefit from. And I really do think you will be so much better off than even your pre-OCD self. And so I'll end with my favorite quote, which is that without our struggle, we wouldn't know our strength. And I love it because, yes, it doesn't mean we want our struggle. It doesn't mean you would have wanted to have OCD. Of course not. We would all wish and hope that we could take it away if we could. However, that is our struggle. It's something that we have to go through. We can't change that. But what we can know is that the strength we will derive from it is so much greater because of it. And so there is something that can come out of it that can be beneficial, right? That we can learn from, that we can grow from, and that honestly other people can learn and grow from as well. All right. We are going to hop into our last couple questions. Next question is 1153 is, are there suggestions on how to start the recovery process while finding therapists? ADHD and bipolar 2 make recovery attempts feel too overwhelming more often than not.
Yeah, like Liz said, like even getting some of those more like self-directed books, right, to to start reading or start engaging in while you're in the middle of finding a therapist can be really helpful. And then also finding providers that specialize in these other areas like ADHD or bipolar. You might have to have multiple providers on your team that work together, but making sure that the provider you're working with has a good understanding of what you're experiencing too.
100%. So go to iocdf.org. You 100% can find resources and support. And there are many individuals who, three things. Number one, there's a lot of clinicians who have subspecialties. So you can find somebody who has experience working with ADHD and bipolar as well. Number two, sometimes you need a different level of care. And I talk a lot about this, that oftentimes I think when people start treatment, if they're not getting better, they think treatment doesn't work for them. When the reality is it may be not the right provider or not the right level of care. So sometimes you need more intensive treatment. You need a day program. You need a residential option, because those of us like that work in residential, like I do here at OCDI Texas, we specialize in comorbidities. So it would be very rare that we get patients who have only a diagnosis of OCD. Most of our patients have comorbid diagnoses, and we're working with that together, and we're developing individualized treatment plans for these more complex, not to say complex cases, but complex diagnostic picture, right? That like traditional just OCD ERP might not work alone. You need to incorporate other interventions, medication management, all of that as well, and have a team. So be really thoughtful about who your treatment team is and what your treatment approach can be, because sometimes it's simply the level of care, right? And the level of treatment that you're getting that needs to be adjusted. However, treatment still works. It doesn't matter if you have comorbidities, like as long as you get the right team and you're addressing different comorbidities with those evidence-based interventions. So we wouldn't do ERP for ADHD and bipolar, right? We'd do ERP for OCD. We would do different behavioral interventions and medication interventions for ADHD and bipolar. So we want to be really thoughtful about making sure we've got somebody, or at least multiple people, who specialize in our different presentations. Well, awesome. Well, Ashley, we are right about on the hour mark. And so I just want to say thank you. Thank you so much for sharing so much insight into maternal mental health, but also OCD as a whole. As we wrap up, would love to hear any final thoughts you have about both maternal mental health and some hopefully messages of hope for that group of individuals.
Yeah.
As a whole.
Even reading through all the comments that people are saying, one that stuck out was that, right, the exposure therapy is hard, but that it's so worth it. And I really want to amplify that I think as providers, we try to understand just how hard and what we're asking our patients to do, right? Every day we're asking them to do things that they do not want to be doing, that their brain is saying bad things are going to happen if you do these things, and they're still so willing to do it. And that we would ask them to do if it wasn't worth it and if we knew it wouldn't be life-altering and life-changing. And so trying to stick with it as best as you can, because we know that there's so much good out there post-ERP treatment. And then continuing just to try to provide psychoeducation and awareness for postpartum and perinatal mental health, specifically OCD and anxiety. I know because we're in the OCD world, we talk about OCD and anxiety so much, but sometimes like in the general mental health world or just like an OB, they talk a lot more about like postpartum depression, and oftentimes OCD and anxiety are left off. So continuing to have those conversations is really helpful.
100%. Yeah. Every time I go to my follow-up appointment and they ask specific questions, they never ask about OCD. And I want to be like, ask about some intrusive thoughts. Specific thoughts. It's so important.
Exactly.
Yeah. So, well, thank you so much. I know this is a topic area that's so important and one that's often not talked about. And we certainly need continued resources and support, because we want people to know that it is very common to experience this uptick in symptoms or a first time in kind of severe symptoms during these periods. We want to normalize that. And we want to normalize that treatment still works and that treatment is amazing. And so if you are experiencing an uptick in symptoms in the perinatal period or in general, we want you to seek out effective treatment. And so make sure that you're seeing a specialist who can help provide guidance and support, and who can not just diagnose you, but can provide treatment, because treatment still works. It doesn't matter if you're in the perinatal period, treatment still works. If you're out of that period and you're struggling, treatment works. You just have to get with the right provider and the right treatment.
Even if your kid is 5 and you're like, I'm out of postpartum, it doesn't matter. Still seek out treatment. Yeah.
100%. It is never too late to seek treatment. And ERP for OCD or the evidence-based intervention for whatever diagnosis you're living with really does work and can get you to a place of not just functioning with your disorder or struggling with your disorder, but a place of freedom. And that's what we fight for and will continue to fight for. So thank you, Ashley, for your work and your time and all of your amazing insights. And we hope to have you back on a live stream soon. As always, you guys, please visit iocdf.org for more information, for support and resources. Otherwise, we will see you back at our live stream next week, same exact time, Wednesday, noon Eastern time, right here through IOCDF.